American Cleaning Institute, where I am Senior Director of the Human Health and Safety. I would like to welcome you all to this fourth session within our Advancing the Science webinar series on chemical-induced asthma. Today, we also welcome Dr. Scott Dodson, who will be presenting our webinar focused on the topic of setting exposure limits for chemical allergens. The American Cleaning Institute is glad to be hosting this webinar series and also to be working in collaboration with the Toxicology Excellence for Risk Assessment Center at the University of Cincinnati. They are assisting us in this project's development and implementation. And we are also pleased that this webinar series has received the endorsements of both the Society for Toxicology and the Society for Risk Analysis. The American Cleaning Institute, or ACI, is a trade association based in Washington, D.C. ACI is the home of the U.S. cleaning products industry, and it represents a $30 billion U.S. cleaning products market. ACI members include the formulators of soaps, detergents, and general cleaning products as used in household, commercial, industrial, and institutional settings. Our members also include companies that supply ingredients and finished packaging for these products, and oleochemical producers as well. ACI's interest in sponsoring this webinar and series is to advance our understanding of the science underlying the relationships between chemicals and asthma, especially with respect to the cleaning products and the consumer products in general. I would like to now hand the program over to the associates of the University of Cincinnati Terrace Center, who will be moderating today's webinar.
All right, thank you, Fran. Before we begin, if you have any technical difficulties, please call the number on the screen. It's also in your registrant emails. If you have any questions during the webinar, please submit them using the question function located at the bottom of your GoToWebinar toolbar. At the end, the moderators will summarize key questions, and we'll address as many questions as possible within the time allotted. If you need assistance sending questions in, please send a chat to Patricia Nance, and she'll help you. The goal of this series is to gain a comprehensive understanding of the current state of knowledge and data gaps surrounding asthma risk assessment. This can be used to guide development of risk assessment approaches and to address gaps and uncertainties in asthma diagnosis and research. We're using this series to discuss the utility of hazard characterization approaches in identifying potential chemical asthma risks and protecting against harmful exposures. And today, we're going to have Dr. Scott Dodson from NIOSH give a presentation on setting exposure limits for chemical allergens, and especially understanding the challenges associated with that. And with that, I'm going to pass over the phone here to Scott.
Hello, everyone. Thank you for joining us today and giving me the opportunity to speak with you about research efforts underway at the National Institute for Occupational Safety and Health. That is where I am employed as a lead health scientist and a senior team coordinator. Basically, what we try to do is develop authoritative recommendations for chemicals such as allergens and ones that cause cancer or non-cancer health endpoints. I'll get into that in greater detail here in one moment, but right now, I think it's important before we get into my presentation to talk about the other three that have already occurred as a part of this seminar series. They've been going on for about 6 months now. The first one started with Dr. Bernstein, who's from University of Cincinnati. He's a clinician who is well recognized for his expertise in asthma, both immune and non-immune mediated asthma forms. And he basically talked about the clinical side of asthma. How do we diagnose it? What are the complexities associated with it? Where is research going? What do we need to do to better help the individual who is being basically overcome by asthma, regardless of what causes it? The second presentation occurred in April. This is from Dr. Bascatier, who is a world-recognized expert in immunotoxicology. If you look at publications on what's called the dermal LLNA, the local lymph node assay, David was one of the pioneers on this and really helped perfect that model and made it to be the validated gold standard for dermal sensitization that it is. But David really went into the causes of asthma, the mechanisms, the toxicology, and really got into the basic and the hard science on what is the cause of asthma from both the immune and the non-immune standpoints. The next presenter was Judy Lacan in June, and she hit more on the environmental exposure side of things. So the first one was the clinical, the second presentation was on hazard characterization and toxicology, and then the third one was looking at how do we monitor for environmental exposures, especially from an indoor air quality standpoint, and the impact it has on respiratory health. She, from my understanding, she not only tackled the quantitative side, but also the qualitative side of how do we do risk assessments for indoor air quality issues. Today, I'm going to change the pace a little bit and focus in on the workplace. As I said, I work for the National Institute for Occupational Safety and Health, and we focus in on protecting the lives and health of workers. Although we, consumers and people in the environment, residents are important, our mandate, which I'll explain in here in a moment, is strictly focused in on how do we protect the worker. But for me today, what I'm going to do is have four primary objectives. The first one is just to impress upon you how important it is to protect workers from chemical allergens, the impact that it has both from a health standpoint and an economic standpoint on this country and other developed nations. Then we're going to talk about the role of NIOSH and how we perform occupational risk assessments, and then get into the actual topic of how are we setting OELs for chemical allergens. And then finally, we're going to talk about highlights of future areas of research. There's a lot that, regardless if you're in consumer safety products side, environmental, community, residence risk assessment, or occupational, or even the clinician side, there is a lot of research that if we could actually get it underway and start utilizing it, we can better protect all areas of our population and from chemical allergens, which have a much higher impact on our health and well-being than what we realize. So NIOSH is not as well known as other federal institutes. If you say EPA, everybody understands that's the Environmental Protection Agency. If you say NLM, most people understand that's the National Library of Medicine. And we could continue with all of the acronym suit that we like in the federal government. So in 1970, there was the OSHA Act passed, the Occupational Safety and Health Act, and what it did was mandated that laws and research be conducted to protect workers. More specifically, within the Department of Labor, two major federal agencies were started. One of them was MSHA, which is Mining Safety and Health Administration. The other one was OSHA, Occupational Safety and Health Administration. The way I like to break this down is if it's below the ground, MSHA takes care of it. If it's above the ground, OSHA takes care of it. That's not 100% technical, but it's probably the easiest way to say it. But when we look at MSHA and OSHA, they have specific regulatory mandates to not only develop laws, but enforce laws aimed at protecting the lives and health of workers. On the opposite side, the third agency that was developed was the National Institute for Occupational Safety and Health, or NIOSH. We have no regulatory authority to speak of. What we do is strictly public health research, and we are intentionally put into the CDC, the Centers for Disease Control and Prevention, because our goal, our aim, our whole purpose is to figure out ways to prevent diseases and injuries from happening for the workforce. If you look at statistics, anytime in our population, 40 to 60% of the population is a viable worker, and we have a lot of injuries and illnesses that workers are going to experience that you're not going to have anywhere else. So it's a small research agency that's really trying to tackle a big problem. Well, when we start talking about chemicals within NIOSH and how do we develop authoritative recommendations and directions on them, it really comes down to one simple phrase within the OSHA Act that we often say our mandate, our direction, and our authority to do this comes from. And it's the line, if you're looking at your screen right now, that says describe exposure levels that are safe for various periods of employment for toxic materials or hazardous or harmful physical agents and substances. Kind of jumbled that around a little bit, but the main point is we are tasked with looking at toxic materials, physical agents, and other substances that can be deleterious to the health and lives of workers and figure out what is a safe level for them to be exposed to for different periods of employment. So when we start looking at risk assessment, when we get into trying to protect somebody from a chemical that's entered into commerce or has been existing for a while in commerce, this is where we hang our hat at saying this is why we have to do it, because we are specifically mandated by the OSHA Act. Well, within NIOSH, within the occupational health profession, there are multiple occupational exposure limits. It doesn't matter if you're in Germany, the EU, Japan, or anywhere else outside of the United States or in the United States. There are just certain standards that we've all come to accept. There were certain types of occupational exposure limits, such as a time-weighted average one, which means that over an 8-hour full shift day, we're going to try to figure out what these people are being exposed to and what is safe and unsafe. Within NIOSH, we call this 8-hour time-weighted average, OEL, a recommended exposure limit. Now, if you are familiar with the occupational safety and health arena, that is different than what OSHA does, which are permissible exposure limits, which are legally enforceable by the weight of the law. OSHA has the weight of the law, NIOSH has a recommendation. But we have the REL, the REL, which is a full shift, which is intended to protect workers really from repeated exposures to low levels of chemicals over a working lifetime. Typically think of these more for preventing cancer and non-cancer health endpoints, such as maybe long-term respiratory problems, such as chronic obstructive pulmonary disease, maybe neurotoxicity, reproductive toxicity. We then have another type of recommendation called a short-term exposure limit, or STEL. These are typically based on 15 minutes. They're really meant to help understand episodic exposures. So if you have a worker who's doing a 10, 15-minute task, and we want to know what the exposure is because it has the potential for a relatively high exposure during that period, most industrial hygienists and occupational health professionals will be trying to take short-term exposure limits or taking samples that can be compared against short-term exposure limits. And once again, these are really aimed at preventing and limiting peak exposures. We often think of these more for sensory irritation, CNS effects, things that can very quickly sneak up and overwhelm people or cause people to have to be removed from that work environment, such as just an overwhelming irritation of the respiratory tract. We also have ceiling values that are represented just by the letter C. These can be associated with a REL, a STEL. They can be used independently, but typically what we try to use, these are ones where we say there is, at no time is it ever safe for people to be exposed above a certain concentration within the workplace. There's no time duration associated with this, but what we say is that there is no safe time, or there's no sufficient, there's various health effects associated with it, and there's just you should never be exposed above that. Sorry, got tangled up on words right there. The last one is more of a recommendation that's associated with respirator use and these once-in-a-lifetime acute exposure events where people can be overwhelmed very quickly and be prevented from escaping their environment, have irreversible health effects or life-threatening effects. And so where the first three are really intended to be protective so that people do not experience health effects with ideal H values or immediately look dangerous to life or health may still be expected. So mild irritation may still occur while the person is leaving the environment, but you wouldn't expect it to get to the point where they have a severe irritation that could incapacitate them. But regardless of which of the four types of authoritative recommendations we produce, we have a general process that people are very familiar with, regardless if you're in consumer safety products, environmental side, or the occupational side. The National Academy of Science through the National Research Council in the 80s came out with this four-step paradigm that we just call the risk assessment process that links in with risk management. And the idea is that you start off with hazard characterization, formerly known as identification, and you walk through this process of trying to figure out what are the hazards associated with the chemical. Is it an allergen? Is it a carcinogen? Is it a mutagen? And so forth. And then you figure out what people are being exposed to, and that is your exposure assessment, and then you have your dose response assessment, which is where you look at all the data, either human or animal, and compile it so that you draw out and understand what the dose response curve is. We'll go into this greater detail, but it's just what is the magnitude of response associated with a certain exposure. And then finally, you compile all this together and you come out with a risk characterization that actually describes the risk and puts it in context of the exposures people are actually experiencing in comparison to the dose response assessment and the overall hazard of the substance. Well, I know this screen is a little vague right now, but the reason I'm putting it up is NIOSH a few years ago embarked upon this idea of we really need to understand the risk assessment process that we're moving into for developing OELs in the 21st century and beyond. So Dr. Mayer, who's in the room right now, myself, several other researchers in and out of the Institute wrote these series of 11 articles that should tackle all of the major components of the risk assessment process for setting OELs. Some of them look at how do we handle uncertainty, some of them are dosimetric adjustments, so how do we calculate the dose that's actually getting into the lungs and into the body, how do we use new cutting edge research on systems biology and biomarkers, and how do we handle exposure assessment. So we really tried to understand how do we address hazard characterization, exposure assessment, risk characterization, and the dose response, and anything along with it. A few of these papers tackled specialty issues such as cumulative risk assessment, genotoxicity, or chemical allergens, which was the paper I led. And this is the name, publication date, everything from that paper. If you're interested, I'd recommend that you go and get that. It was published in the December issue of the Journal of Occupational and Environmental Hygiene. The interesting thing on this is when Andy and I, Dr. Mayer and I, started writing this paper, the title initially was Setting Occupational Exposure Limits for Chemical Allergens. Our goal was to crack the Gordian knot that says you cannot set chemical or OELs for chemical allergens, and we were very confident in our ability to do this. And as we added the other subject matter experts that you see and listed as co-authors here, such as Dr. Ed Kimber out of the UK, and then Dr. Siegels, Anderson, Green, and Stefaniak from NIOSH, we quickly realized that our understanding of the complexities of the biology and the mysteries around that was really inhibiting our ability to set OELs, where we thought that people just hadn't taken the time or really hadn't been able to crack the code, and we thought we'd be able to. We quickly realized it's not that there hadn't been a failure, there had been a failure of people trying, it's just there's a lot of uncertainty. And that's really what that paper focuses in on, and that's why we stopped trying to tell people how to set OELs and start telling them, here's the challenges we have to overcome if we truly want to do that. And that's what I'm going to focus on for the rest of our time together, the next 25 minutes or so. So why are chemical allergies so important to the workplace, to the worker, to our civilization, our population in general? And in short, it is one of the most common immunological manifestations that humans experience. Within workers, we typically think of this as forms of allergic contact dermatitis. That means you get exposures on your hand to a chemical and you'll have a whole body rash. Think of poison ivy. Or we have respiratory effects. Typically, we think of this as occupationally induced asthma or allergic rhinitis, but there are exceptionally high levels of morbidity, and I've got some data to support that statement here in a minute. Unfortunately, we really don't understand the mortality associated with this because you cannot tell the difference between occupationally induced, or excuse me, allergy-induced asthma and non-allergies oftentimes when it results in death. But what we're referring to when we talk about chemical allergies is just simply an inappropriate and exacerbated response of the immune system to the presence of an allergen within the system. And this can cause anaphylactic shock and death. It can cause respiratory distress or something as mild as just allergic contact dermatitis. Now, the data on this, as I've already said, it's one of the most common forms of immunological manifestations in humans. But when we break this out into the available data, we know that there are hundreds of chemicals that have been positively identified as causing allergic contact dermatitis. We also know that allergic contact dermatitis consistently in most developed nations, EU, United States, etc., typically ranks at up to 15% of all occupational diseases. When you look at the monetary side of that, I've seen reports from 10 to 15 years ago that over $2 billion a year is spent on occupational skin diseases to the treatment and both from the employer and the employee standpoint. But now with our current economy, I'd say that those values are much, much higher. I would estimate it's probably $5 billion plus a year, just given inflation and the way our healthcare system is working. But allergic contact dermatitis is not only affecting a lot of workers, but it's also causing an economic burden for the country. When we look at allergic respiratory diseases, which is the one that we really want to focus in on because of the high levels of morbidity, it's really hard to distinguish what is being caused by allergies or allergens and non-allergens. This is what Dr. Basketeer David went into, I believe, in April. So if you want more information on the mechanics of that, I'd suggest you look at that. But what we know is that up to about 15% of all cases of adult asthma are specifically linked to the workplace, that there are occupational factors that are either causing it or making it worse. When you look at the population attributable risk, is somewhere between 10 to 25% of the population of adult asthma is caused by occupational exposures, and this puts it at up to a 300 per million annual rate of new onset occupational cases associated with the workplace. In other terms, that would be an unacceptable risk for most of us in the policy side if we were looking at other health endpoints. So this is a significant burden, and once again, we don't know what the mortality data is on this. When we talk about allergens, we typically break them out based on their molecular weight. There's a funny unit called a Dalton that is used specifically for allergens. Things such as animal and plant proteins, latex rubbers, detergent enzymes, those are typically naturally occurring in many cases. Allergens that have high molecular weight, it's important to realize that the reason we look at the weight is the bigger they are, the greater the chance that the immune system has the ability to directly recognize them. They also tend to be less reactive compared to the low molecular weight allergens such as diisocyanate, the organic anhydrides, and certain metals. These things are highly reactive, they're electrophilic, but they are so small that they have to actually be bound to endogenous proteins before the immune system can recognize them. What we typically do in NIOSH are look at the low molecular weight chemicals. This is what we set most of our OELs, our RELs, our TLVs, and ideal H's on, and that's really what this paper and what I'm focusing in on today is the ones in blue here. Despite the mortality or the morbidity data showing that allergens are an important hazard that we need to get our hands wrapped around, and we understand the economic complications for them, there's not many OELs currently out there. Hopefully the majority of you on this call are familiar with the American Conference of Governmental Industrial Hygienists. It's abbreviated as ACGIH. They're one of the leading non-governmental organizations that produce OELs. They call theirs TLVs, threshold limit values, and they've been doing this since the 1940s to 1950s. If you look in their booklet that has all their TLVs, there's 600 to 700, 800 different chemicals listed. They constantly come out with new chemicals that have TLVs or they update. Out of those, from what we can find, there's only 13 chemicals which are listed on the screen here. 10 of them, I believe, are low molecular weight. The other 3 are high molecular weight compounds that are actually based on preventing respiratory allergic effects, such as sensitization or asthma. And what that tells us is that there's definitely a problem because we're not sure we're truly protecting workers as well as we need to, because allergic effects may occur at concentrations much lower than what non-allergic effects can occur at. So there is definitely a need for us to understand the science and the biology behind this better. Well, the 4 critical challenges that are highlighted in the paper and that I'm going to discuss now can be summed up here. That 1, what is the biology that's driving that chemical allergy? What is happening from a mechanistic, from a toxicology standpoint in the body, and how do we understand that and use that information to conduct risk assessment? The next part is how do we look at the dose response assessment? Finally, how do we do exposure assessment and the critical health endpoint selection? Well, hopefully everybody's going to take about 10 minutes now and look over this very complex image and really understand what chemical allergens are all about, how they work. But I'll put this up because when we think of chemical allergies, this is just a snapshot of the complex process that's occurring within the body. You have an exposure, you have the antigen, the foreign bodies moving in, you have cells activating, you may have antibodies activating, you have cytokines being released, you have all of this biological process that's kicking in, and that's just for the first phase that we refer to as sensitization. Did it kick over? Excuse me, I've got a slide missing.
Try again.
Okay, thank you. And then once the body is primed or sensitized, we then have this other subsequent set of events that happen after additional exposures happen. For this conversation, for most of us, we don't need to go into this detail, and to be practical, we've developed this very simple, it's almost laughable compared to how complex the process really is, just to help people understand. The first box, you have some type of initial exposure. You have the chemical allergen that either is inhaled or it gets on the skin. It can happen once, or it may take hundreds, if not thousands of times a person is being exposed, such as by pollen or mold, before the sensitization occurs. When sensitization occurs, what this means is that the body is primed, that there has been some biological mechanism triggered where the person has actually been set up now, so on future exposures, they're actually going to have what we call an allergic response. It's completely symptomless, it's subclinical. People will not realize that this is occurring to them. Then after another exposure, once the body is sensitized and primed, that's called the elicitation phase. And this is clinical manifestation. This is what Dr. Bernstein and others will see when people show up saying, I'm having trouble breathing, or I've got allergic contact dermatitis. We're actually talking about elicitation. And this is where you see the hypersensitive reaction, the swell in the skin, the contraction of the bronchioles, the difficulty breathing. And once again, like I said, this is a very simple drawing, but it's just to help illustrate a very complex idea to people who we don't need to know the depth, but what we do need to know is the basic terminology and what's happening. The reason we need to know that is when we're trying to select a health endpoint, do we say we really need to focus in on preventing the disease from ever happening, which means we need to focus in on sensitization, or do we need to focus in on what's happening once a person is already primed and they're having allergic reactions? This is actually somewhat of a debate within the scientific circle that does this, because ideally you would prevent people from ever having sensitization, which would mean you'd prevent all future cases of elicitation. But from a risk assessment standpoint, would it not be more health protective to focus in on the people who are already sensitized, and then that way you can protect that population and the other? Being a person who wants to prevent disease, I typically focus in on let's preventing all future cases, and then we'll have to figure out what to do with the other group. But like I said, there's a large amount of debate on that. For this, when we're looking through the hazard characterization, we could potentially, if data are available, look at certain things like which cells are being proliferated. We know that certain mechanisms, certain pathways that specific allergens take will cause lymphocytes, which is one of your white blood cells, one of your immune cells, actually proliferate, and you'll have a larger abundance of them. Well, when that occurs, it normally means that you have been sensitized or are in the process of being sensitized. You can look at cytokine, or these chemical messengers. If these things are being released, it could be a representative, it could be a marker that sensitization or elicitation is occurring. You can look at IgE, which is an antibody, within either, you can look at the concentration of it or the change of it within the total serum, or you could also look at, you could challenge people or animals with the chemical. Let's say you think they're sensitized and you challenge them, and then if they have a reaction, then you can say, yes, they are positive. This is kind of like the patch test that clinicians use, but that one's probably a little too dangerous when you're talking about respiratory reactions, because you really don't want to induce asthma in people. So there's debates on which way we should go here, sensitization versus elicitation. Well, moving into the next conversation piece, dose response assessment. Typically, this is where we are trying to understand the magnitude of exposure associated with a certain concentration. Typically, when I give this presentation or when I talk to people, there's at least one college student in the crowd that gets this, but when you refer to alcohol, most people understand it. If you drink a beverage, one beer, most people will not have any response. You drink a six-pack of beer, you'll start having a buzz. Some people start having a heavy intoxication, but as you drink more, your intoxication increases. That is a simple analogy of a dose response assessment. That is a very simple analogy of, if we know the anticipated effect that somebody's going to have with 6 drinks, then we can figure out what is safe for, let's say, people to drive, or what would be an appropriate driving level. When we're looking at dose response assessments for non-allergens, we draw these dose response curves like you see on the screen. We have these different points of departure, which are potential places where we may base our risk assessment on. the one that says NOEL, N-O-A-L-E, stands for no observed effect level. We have another called LOEL, lowest observed effect level. We have ones that are calculated, such as the BMD, which is benchmark dose. But the point is, normally with non-allergens, we can find some part on the dose response curve that we can say, okay, this is where we're going to base our recommendation on. This is where we're going to start extrapolating out our OEL or risk estimate. The complication that comes in with chemical allergens is because of the sensitization versus elicitation issue. If you are a person that thinks that sensitization should be the basis of an OEL or a risk estimate, then you could potentially draw out, if you could figure out what the health endpoint is that you're looking at, this blue line, which would be this is once again a hypothetical dose response relationship for sensitization. But then when you look at the elicitation, well, it takes a completely different shape because it appears that there is no safe level exposure at times, that a de minimis exposure may actually trigger a response in some people if they're sensitized enough. So we're not sure on these dose response curves, where should we base our risk assessment? Do we do the blue line or do we do the red line? The blue line appears to have a threshold response, which means that there is some level of exposure that should be safe. The red line, based on the data that are out there, appears to be more of a linear response, which means there is no safe level exposure. But we just don't have enough data to conclusively say where should we hang our hat at this time. So when we start talking about dose response characterization, areas that we really need to focus in on is the level of sensitization and the severity of elicited response. When we say the severity of elicited response, if we're talking about life-threatening respiratory distress, such as asthma versus allergic contact dermatitis, that will change how we look at conducting a risk assessment. I would prefer, especially if it's for something that's life-threatening, to stop people from being sensitized. But the level of sensitization versus the severity of the response has to be considered when we're at this phase. Unfortunately, most of the data that are available for these low molecular weight allergens are insufficient. There are exceptions. When you look at human data, there have been several isocyanates that have had OELs developed for them, and that is because there are large epidemiological studies that have been conducted over the last 10, 20, 30 years that allow us to construct exposure response curves. Most chemicals, we don't have that luxury. So we default to animal data, which is common risk assessment practice. But unfortunately, from the respiratory standpoint, we lack a validated model that can tell us what the human response equivalent would be. If you look at dermal exposures, we have that gold standard bioassay that I discussed earlier called the dermal LLNA, and it has been validated, it has been vetted by the National Toxicology Program and other well-established organizations that conduct this type of research. And we understand that if it's the accuracy of it, it's been validated. We even can understand the impact from animals to humans. We don't have that luxury at this time in humans, or excuse me, for the respiratory direction. So for dose response characterization, there is a large amount of uncertainty that needs to be overcome before we can do this successfully. Well, in the next step of the risk assessment paradigm, we have exposure assessment, and there's really two large issues that need to be addressed. The first off is the temporal patterns of exposure. When people are exposed within the workplace, at times they may have a peak exposure, and this is where we would try to develop a short-term exposure limit or a STEL, or they may have cumulative exposures where just throughout the day for the majority of their working lifetime, they are being exposed to low-level exposure concentrations of the allergen. The data, because it's so scant for most of these chemicals, it's unclear whether or not it's cumulative over time exposures that result in sensitization, or can the short-term exposures, the peak exposures, really be the driver. And this does matter because if we understand that it's peak exposures, we need to really limit the concentration for 15 minutes or 10 minutes. We have to develop a different type of recommendation versus the long 8-hour exposures. The other component of the exposure assessment that needs to be overcome is the impact of aggregate exposures. This is exposures from multiple routes. typically within the workplace, we always develop OELs, recommended exposure limits, TOVs, whichever the organization is, to protect workers from inhalation exposure. To my knowledge, there are no dermal occupational exposure limits, and when you look at the OSHA regulation, I believe there's one chemical, and I think it's MMDA, or yes, MMDA, that has an OEL that's based on dermal, but they still set an inhalation exposure limit. And so with many chemicals, that's okay. You stop the inhalation exposure, and you should limit the probability of the disease from happening. Well, with chemical allergens, there are new data coming out every year that shows there's a crossover between dermal exposures and inhalation exposures. And what I mean by that is you can actually stop inhalation exposures, but if dermal exposures continue to happen, you may induce asthma. And that's kind of a novel idea of you get something on your skin and it may cause asthma versus you inhale it and you get asthma. So when we set an OEL for a chemical allergen and we don't protect for or take into consideration the dermal component, the multiple routes combining their impact, are we truly protecting the worker from that health endpoint? And right now it's unclear. Let's see. So just as a recap on those last few slides before I move into the next portion is, our ability right now to develop OELs for low molecular weight allergens is truly based on data availability. If you have a chemical that's been well studied, such as many of the isocyanates, the data are there, we can develop the exposure response curves, we can come out with scientifically defensible OELs. In many cases, this is not available. So from the data types, the human data are limited. Animal data, there's variable levels of data for the different chemicals. If there's dermal data, we're trying to figure out how can we conduct route-to-route extrapolation. But until we have the respiratory equivalent to the dermal LLNA, we're slightly handicapped on this. There's a growing body of the high throughput in vitro data. These are the cell lines. We're very interested in these as a profession because it's a growing body of data. This seems to be the trend that toxicology data is going to, but it's unclear of how to apply this data at this time for risk assessment processes. The National Academy of Science has come out with their tox testing in the 21st century. It really emphasizes the use of in vitro data, but once again, we're not sure. If you take human cells out of the lung, you grow the cell line, and then you're exposing them to an allergen, does that really replicate the whole complex biological process that I've demonstrated on the first couple of slides? And the answer is it's unclear at this time. Then we also have the in silico models, the mathematical predictions. These are growing in popularity. They're also growing in use, and they are being validated very slowly, but the majority of them are not validated right now. And I've heard one person in the pejorative way say it's about like flipping a coin on whether or not you can predict whether or not something is a sensitizer or an allergen. So not to paint a bleak picture, but what it is more of there's a lot of opportunity for good research to go on both at the academic level, on the private industry side, and on the government side to help overcome these issues. Well, what are we doing from an occupational standpoint? Well, it really comes down to what we call alternative hazard approaches. These are not full risk assessments. They're more qualitative hazard designations. GHS, which is the Global Harmonization System for Labeling and Classifying Chemicals, which was a United Nations effort that now OSHA has incorporated into the HAZCOM standard, has actually got a hazard statement both for skin and respiratory sensitization. If you're not familiar with GHS, you can go online and just Google it, and you can find a lot of information. The organization ACGIH has several different sensitization designations, one for respiratory, one for dermal, and then just a generic one for sensitization. In 2009, NIOSH developed a new skin notation profile paradigm where we actually assigned multiple notations, everything from can a chemical cause a fatality if it gets onto your skin, to severe corrosion, to sensitization. And one of our documents that was out, published I believe in 2011 on BPA, bisphenol A, has been assigned that notation of sensitization. If you're interested, you can follow the link that I've included on the screen. Another approach that I have not listed here is hazard banding, which is this concept that is underway within the occupational arena of using the available data to categorize chemicals within bins or bands. The higher the letter, I believe E is the highest, most severe, compared to A, which is the lowest. If a chemical is given an E, it means that a lot of effort needs to be put into controlling and limiting exposures. These are being done, these banding approaches are being championed because it takes so long to get OELs out of most of the organizations, including NIOSH. And so sensitization is definitely one of the major categories included within future banding efforts. Well, at this time, if anybody's wondering on the phone, if I had listened to this presentation, I'd be thinking, well, there's not much we can be doing from the risk assessment side. And I absolutely agree with you until additional data comes out. But what you can do is develop a comprehensive risk management approach. If you're an employer, if you're someone who's going to be working with these allergens, there are proven risk management processes, everything from how you conduct medical monitoring and surveillance on your employees to how you apply what we refer to as the hierarchy of controls. At times, if you can substitute one molecule for another, it would be strongly advocated, but I realize certain processes that is just not either economically or technically feasible to do, and so you default to other things such as engineering. Can you develop some process? Can you develop a process where things are isolated with better ventilation to prevent exposures in your workers? And that is what the Table 4 here advocates. Table 5 actually provides a checklist summary of key considerations if you are concerned about the health risk of allergens in the workplace. So just let's walk through this checklist and ask these questions. And if you start getting the majority of them are yes, then you do have an allergen issue potentially, and you need to look more into comprehensive risk management. Another diagram that's within this document, if you're interested in looking it up, is this very complicated flow chart that breaks down the different risk assessment steps from hazard characterization, and we've included risk management on those. I didn't go over this. I don't really like to emphasize it because it's hard to see on a screen. But if you get the paper, you can see this in greater detail, and you can see how all of these kind of fit together and have a flow chart that helps you walk through them. But I've already kind of plugged these three areas several times throughout the presentation, and I want to do it a few more times because if there's a researcher who is looking for a new area to move into or trying to redefine how they're running their labs, we really need a validated respiratory animal model. I know that there are researchers in our NIOSH Morgantown lab looking into this. I know that there is research underway, I believe in Europe. They're doing the brown Norway rat model, which holds a lot of potential as it's becoming validated and additional chemicals are being run through that process. We also know that there's other research going on that might be able to apply this, but if we really want to start developing more OELs, more risk assessments, both for consumer safety products and the environmental side, we need that respiratory animal model. The next component of it is determination of the relevant exposure pathways or patterns. We need to understand, is it peak, is it cumulative, or is it a combination of those two exposure patterns that are really contributing the dose, the concentration that's triggering sensitization and elicitation. And the last part is we need to understand the mechanisms that drive the ability of most allergens to affect a person or an animal via multiple exposure pathways. On the surface, it appears to be different mechanisms. There's cells called TH cells. Typically, they're called TH1 and TH2. It seems like most dermal occur through TH1, most respiratory occur through TH2, but for some reason there is crossover. And until we get a better understanding of the basic biology behind this process, it's going to inhibit our ability, and we're going to have to focus more on the risk management side and less on the risk assessment side. So in summary, low molecular weight allergens are a significant occupational hazard. Just to reemphasize that large numbers of workers are being exposed to these chemicals. We have high levels of of morbidity, both within from allergic contact dermatitis and occupational asthma. It's up to about 300 per million cases of new onset of asthma are contributed to occupational factors, and many of those are most likely caused by allergens. So it's also an economic burden. We have significant gaps within the scientific and technical knowledge on allergens, which are preventing us from developing OELs. And until these gaps are filled, we're really reliant upon these alternative approaches such as hazard banding or GHF or NIOSH qualitative hazard designations. And I cannot emphasize the need when there are chemical allergens in the workplace to have a comprehensive risk management program running from everything from good hazardous communication or HAZCOM, which the incorporation of GHF will help because they do have these designations for allergens, to medical monitoring, to use of PPE, to engineering controls, and potentially substituting that very chemical out. So in conclusion, that is my slides. I do want to point out that this is a typical NIOSH disclaimer that I have to read. The findings and conclusions in this presentation have not been formally disseminated by NIOSH and it should not be construed to represent any agency determination or policy. And then finally, if you're interested in contacting me, here is my information. And I believe Melissa and Frank can provide that information to you if you need it, and then I'll turn it over to them for questions.
All right, thank you, Scott. I'm actually going to allow Dr. Andy Mayer to grill you here. He's got a few questions for you.
Okay, just a reminder for folks on the webinar, if you have additional questions, feel free to send them into us via the chat feature. But one kind of housekeeping question just to get us started is, folks have asked could you reiterate where the figures and the materials that you were presenting?
Sure. I'm going to go through the slides real quick, folks, and redo this whole thing just so you get it. Actually, let me pull up one slide. I'm going to leave this up for the rest of our talk, but if you look in the Journal of Occupational Environmental Hygiene, the December supplemental issue has all 11 of the NIOSH articles on how do we set OELs and the state of the science and where we're going. And this is just one of those articles, but you can see if you have access to PubMed or any of the other scientific databases, they'll be easy to find.
Great. Thanks, Scott. Well, we had a variety of questions.
One thing I do want to point out is that we have made that open access, which means you do not have to pay for it. So if you do not have access to these, you should not have to pay for it, and there should be free versions of it posted to the PubMed website. So, sorry about that, Andy.
Okay, great. Well, thanks for that. So one of the questions relates to the use of different time averaging for OELs. Mm-hmm. And the specific question indicated here that in the cases where you have less information, would the ceiling limit be an appropriate or obvious default to use as opposed to other limits? And I'm going to add on to that question in that I was just noting one of the tables, the different low molecular weight allergens noted. Some had TWAs only, some had TWAs themselves, some had a ceiling, and it didn't seem like that there was a clear pattern to that. I don't know if you could reflect on.
Sure. And Andy is right. I would put that table up, but really I want to leave this up so people can write that down, or write this information down. The table that Andy's referencing is the ACGIH TLVs. There's 13 chemicals listed in it, and he's absolutely right. The majority of them, there is no clear-cut pattern on the way ACGIH has developed those. There's time-weighted averages with cells, with ceilings. There's some that do not have these, and I don't think we understand well enough the peak versus cumulative to say that a ceiling value would be ideal, or that a cell would be ideal, or that a time-weighted average. I think that if we could do the basic research needed to characterize several chemicals on is it peak versus cumulative, that would help us determine. But at this time, I don't want to say it's shooting blind by any means. I'm not a member of ACGIH. I've never sat on their committee, so I don't understand their rationale, and I don't want to misrepresent them. But from our standpoint, we would just have to see on a case-by-case data what the data said. We are currently looking into 2/4 TDI, I believe. And the time frame on that is a little flexible, but hopefully within the next couple of years, that document will be out for external review to the public. And we're currently debating some of these things in-house right now. Does that need to be a STEL? Does that need to be a time-weighted average? And it's right now just, what does the data say?
Okay, well, very good. And we're getting actually a good flood of questions, so I will try my best to summarize some of these and integrate some of them also.
Okay.
One thing to note, or one comment was made that in the past, some folks have used prick testing kind of test as a sort of an effect biomarker for risk management purposes, and at least in some circles, that there's being a push against doing that from the regulatory perspective, and that provides a challenge to how to manage these sort of things. So I wondered if you could weigh in on that and tie it into generally the use of biological markers or measures.
Sure. Biomarkers is one of those areas that I'm definitely interested in, and the biggest hindrance I see to them, besides us not having enough of them and understanding how to interpret the findings. So blood lead levels, if we see blood lead levels, we know, okay, this has this impact on children and this on their intelligence. And we've kind of got some type of metrics for comparison again. Many of the biometrics, or excuse me, the biomarkers that are coming out now, we understand that they're useful, but you go and get a blood draw to see if your cholesterol is high or low. If you don't have that range of normal cholesterols for the population, it's really hard for the doctors to tell you whether or not it's high. And so right now, I think that many of the biomarkers, we don't know how to interpret the data, but there is great promise for them. The one complication that I see that we have to, and I'm not sure how we overcome this, is if you take an allergen that can affect people both from the dermal route to inhalation route, and you show there's an IgE, some antibody going through their bloodstream, and that's your biomarker, how do you know what exposure route is occurring there? And that does come in that's very important to understand of, okay, how are people being exposed? If you say 90% of their exposures is occurring through inhalation and we have some dermal, okay, well, that means you really need to focus in on the inhalation first and then the dermal. But until we understand the complexities of, okay, biomarkers, how do we understand them, how do we interpret them, and then turn around and say, okay, how do we do the multiple routes of exposure? Because even if you don't look at allergens, if you look at organic solvents, if you look at certain metals, the skin is a viable pathway. So we have to take that. The third component that I've heard people take into consideration is, and I think you have to do this with any chemical, of if someone all of a sudden appears to be allergic to a compound that is very common, that means it's not only in the workplace, it's also in the home, it's in the environment. How do you specifically regulate that for the workplace? Because it is the employer's burden to make sure that they protect the employee, but how do we know if their exposures are actually occurring in the workplace or not, just because a biomarker is tipped off? So you still have to couple that with good exposure assessment, such as an air sample or a white sample for the skin.
Okay, good. Okay, well, thanks for the answer to that. And like I said, we have a lot of questions and trying to sort through here, but at least several of the questions relate to high molecular weight questions. So I guess a couple of points to that. One would be, are the items you've discussed relevant or directly applicable, or is there a separate effort related to high molecular weight molecules? And the second part of that is, at least one person notes here that, at least in their experience, the high molecular weight tend to be actually much more, even more potent than low molecular weight in many cases. And so yet sort of are the same kind of approaches and risk management ideas pertinent for that?
Actually, the reason we focused in on low molecular weight allergens is because that was what the other 10 papers were looking at. The slide that I put up that had all the papers listed, we weren't really looking at high molecular weights for cancer, for genotoxicity, for the other endpoints, so we just stuck with the trend. Some of the people that are listed on that paper, such as, he's abbreviated as BJ Green, but Brett Green, he is an immunotoxicologist that really focuses in on high molecular weights. And then Siegel and Anderson also have a lot of experience with it. My understanding from them is, yes, high molecular weight allergens can be just as potent, if not more so. Yes, the risk management should be employed in the same way. Actually, and I think in many cases, because of companies, we're in Cincinnati, and we always have to plug our hometown companies such as P&G that use large quantities of the enzyme detergent. There's a lot of interest in protecting workers from that and the consumers from it, because you don't want to put out a product that is bad, that is going to cause people, you wash your clothes in a detergent, if you do something and then it causes them to have allergic contact dermatitis, you're going to lose them as a customer. So there's actually been quite a bit of research on that. I'm not a subject matter expert on it, but I would wager that you could find something very quickly online or find a consultant who specializes in that. But yes, to directly answer the question, application of a comprehensive risk management plan would be a good starting point to protect people from high molecular weight allergy.
Okay, great. Several folks have asked questions about the use of alternative approaches, and specifically SAR and QSAR, for looking at low molecular weight allergens. Right. Is that something that's been done or considered in sort of NIOSH protocols, and do you see the future for that?
Right. In that skin notation profile document I put up, when we drafted that in 2009, we actually included a caveat in it that says, at this time, we're not looking at in silico models, the predictive models, because they're highly, they're variable. We're not sure how accurate they are, but we thoroughly anticipate that we're going to use them in the future because they are going to be validated. I think that's the trend that we're seeing. We have a brilliant researcher at NIOSH with the last name of Matt, or by the name of Dr. Matt Wheeler, who's currently looking at this of how do we take QSAR models type mentality and use bioassays from in vivo data and actually develop dose response curves and be able to predict not only the chemicals that we have the data for, but future chemicals that we just have basic information like chemical physical properties. I think eventually as computing power and technology moves forward, our understanding of the biology advances and the two of them merge, we're definitely going to use this, especially with the trend of less animal data, which is coming out of the EU. And I'm not sure if the U.S. is going to adapt the REACH model of less animal and more in vivo and in silico models. But yes, QSAR and SAR and anything linked to that, they are definitely developing at this point, and we're going to rely on them in the future.
Great. Interesting question here. In general, in your experience, are these same kinds of limits, including the ones being shown here, applied for construction workers also? And kind of a corollary to that from another question is, to what degree do you envision the exposure assessment and the risk assessment to kind of drive towards scenario or project or industry-specific considerations?
Well, when NIOSH develops a recommended exposure limit, an authoritative recommendation, I don't know of any in our 40-year history that says it's only good for this industry. If we develop something for chemical X and chemical X is used highly in dry cleaning, we may talk about that, we may focus in on the dry cleaners, but if a new use is found for chemical X in another industry, which happens all of the time, I mean, that happens constantly of, we need a chemical, hey, they're using this for dry cleaning, let's see if it'll apply over here, then our authoritative recommendations would definitely be applicable, even if it's not for that specific exposure scenario that it was developed under. I believe that the TLVs, and Andy may be able to speak to that, another group called the WILS, I believe that's the way they all work for the most part. Yeah, MSHA might have some that are specific for mining operations, which that's me speculating on. What was the second part of that question?
Basically, it related to kind of sort of scenario specific, because part of the question that was asked was, in construction you might be exposed to these materials in terms of using a specific product, but also just from disturbing soil, right, or old insulation, etc.
Yeah, the idea of exposure scenarios or risk assessments based on scenarios, that does happen. I believe the EPA just came out with documents that we're looking at worker exposure to a compound called bromopropane. That's an organic solvent now linked as a carcinogen and neurotoxicant. In that risk estimate, exposure assessment that they did, they actually looked at different scenarios such as dry cleaning, vapor degreasing, I believe, aerosol spraying. They had several scenarios where they developed estimates for it or recommendations. NIOSH and most of the organizations don't take that approach, but there are ways to do that. And if you're interested in it, like I said, you can find exposure assessment people who are good at it. There's people at EPA, there's people in academia. We most likely have those people in NIOSH, but we just don't come out with those types of recommendations as an institute for the most part.
Okay, I mean, just for sake of time here, maybe two more quick questions. One person notes that there's actually kind of sometimes a disconnect between something labeled as a sensitizer, for example, under GHS,
right,
and there's the AOEC listing for occupational environmental clinics.
Okay.
So one question is there kind of a agreed to source, or how do you actually identify from the hazard identification step of this process?
Okay.
As kind of a uniform set of information that one would use to determine, is that something like to be a sensitizer in the first place?
Right. And I think that addresses a bigger issue of, is there a harmonized system to identify a chemical regardless if it's an allergen or a carcinogen? And the answer is no. I mean, we have general risk assessment, hazard characterization approaches, but NIOSH, for example, with the skin notation, excuse me, I'm about to sneeze. Sorry, trying not to sneeze here, guys. But for the skin notation strategy process, we tell everybody these are the data sources we use. This is the process that we use to develop our recommendations. GHS, which is not a competitive system, but a companion one, may have different guidelines on how they develop it. I'm not familiar with the AOC, but I'm assuming that they have their own guidelines, and so that's why you don't see the harmonization between systems. It's because we're not mandated to stick with one set of data, one set of rules. Each group does what they think is appropriate. So,
yeah. Great. I'm going to ask one more and then have one final comment based on the very last question we have here. So one more question relates to, are there specific studies that NIOSH does or has or that you're aware of that look at specific types of PPE and their ability to be protective of dermal exposures for chemical allergens?
NIOSH does have a laboratory in Pittsburgh called the National Personal Protective Technology Laboratory, and they are the group that certifies and tests respirators. They do some fall protection, and they do look at some barrier materials. With that being said, I'm not as familiar with that. I know that we have those capabilities. I know that the military is also having those capabilities. Many of the compounds that are being studied these days are more chemicals that are gross solvents that are going to have recognized corrosion, irritation, things like that of the skin, and that they're not really for allergens, or they're looking at chemicals that could be used as warfare agents. As far as what would be appropriate PPE for allergens, off the top of my head, I'm not sure. I know that there are resources out there, and I think it's Forsberg and Mansdorf. They have some recommendations that are chemical specific, looking at different brands. But I'm not sure what we could supply from a NIOSH standpoint.
Yeah. Well, great. Well, we didn't get to all the questions, so I think the rules of the game, assuming Scott agrees, is that for folks who submitted questions and we didn't get a chance to get to them, he'll answer those offline for us, and also maybe reiterate the ones we did receive. One question we did receive, I just wanted to note, is are there ideas about other tools or frameworks for risk assessment for these types of situations? And just sort of as a plug for our future webinar, we're sort of going to be rounding out the webinar series with hazard characterization of risk tools and frameworks, and also inviting back all of our previous speakers to talk about sort of the what we can do now, as well as what the future holds for best practices for risk science related to this topic. So with that, thank you very much, Scott, for answering all those questions, and thanks for all you folks for submitting so many questions. They kept me on my toes. So I'm going to turn this back over to our other colleagues.
All right. Well, thank you, everyone, for joining us. Just a reminder, if anybody is taking this for continuing education credit, you do need to complete the survey that you'll receive at the end of this webinar. And we hope that you will join us for our next session in October. I apologize, I'm bringing up the last slide so that you can see the date and time as well. And we'll send reminders to all of our previous registrants as well. But our next presentation will be on October 21st, again at 11 a.m. It's a Friday. And we'll have Dr. Andy Mayer talking about some hazard characterization approaches for addressing these complex problems that all of our other speakers have very kindly educated us and talked about for a while. We're also going to be having a roundtable session at the end of Andy's talk where we're inviting all of our speakers to come back so we can openly discuss some of these issues and talk about possible paths forward for asthma-specific risk assessments. So thank you again, everyone, for joining us, and we hope to see you again in October.